Hello, my name is Paul Fockens. I'm the chair of gastroenterology and hepatology at the Amsterdam University Medical Center. And I'm doing this gastrointestinal endoscopy interview on YouTube because of our recent acceptance of our publication on a new classification system for complications in gastrointestinal endoscopy, the so-called AGREE classification. Why have we done this research and why have we published this article? We think GI endoscopy has changed dramatically. We are doing much more interventional procedures, replacing surgery more and more. And this has been going on over the past maybe 2 decades, but most prominent now in the last 10 years, I think. Since we do far more advanced interventions, we also have more complications. And if you look at complications, then of course we need to register those, and we do that according to the ASGE, the American Society of Gastrointestinal Endoscopy classification, which was published in this journal in 2010 by Peter Cotton as a first author. In this ASG classification, the biggest impact is the length of admission, and there's less impact for the necessity of interventions to treat the complications. And we think that actually that is where, since we are moving towards so many more interventions, that probably the interventions are more important than the length of stay. The length of stay in hospital are also dependent on frailty, etc., and many more things. Another thing would be that it would be nice to be able to compare our complications with surgery. For instance, in a gastroduodenostomy, we can do them endoscopically now. We can also do them surgically, laparoscopically. And in surgery, the Clavian-Dindo classification has been used all over the world, which is not true from the ASG classifications. The Clavian-Dindo is really in worldwide use, and if we have a similar system, and that's what we did, we tried to adapt the Clavian-Dindo to endoscopy, and I think it would be nice to be able to compare our complications. So what did we do? We invited 80 experts all around the world and just first asked them, do you use any classifications? Which classification do you use, etc.? And then there's a variety. There's a minority, maybe 40% or so of colleagues that use the ASG classifications, but some people use no classifications, no system, etc. So we decided to, as I said, adapt the Clavian-Dindo classification to GI endoscopy, and we then validated it. And the validation was in 3 steps. The first step was, does perception of patients, nurse, endoscopist correspond in the AGREE? Because if we think as doctors that the complication is very severe, but the patient think, well, this is not important at all, etc., then we need to have a correlation between nurses, endoscopists, and patients. The second question we asked ourselves, does the AGREE classifications correlate with the ASG classifications? Because it would be strange if it would be a completely different system with completely different outcome, of course. And then finally, when we went through those steps, we internationally validated it by asking 57 expert endoscopists, actually we invited more, but 57 participated around the world to grade a number of complications and tell them how they would grade it, and if there was accordance with what all the other people did. So what are our results? I think first, most importantly, the perception corresponded in 80% of cases with patients, endoscopists, and nurses, which is an important one. And then secondly, there was a significant correlation with the ASG classifications with a rho of 0.760. And if we then invited our international expert endoscopists to grade those cases, 84% of the example cases were correctly graded. And we also asked them what they thought about the classification itself, and 86% found it a simple classification, which is important also, of course. 98% found it reproducible. They would always fill it out in the same way. Another 98% said it was a logical new classifications, and 96% said useful. So that's actually quite an encouraging result. In conclusion, if you read our article, I think you will find that our conclusion is that the AGREE classifications, which is the new name instead of the ASG, our classification we call the AGREE classifications, provides a standardized and reproducible approach to the assessment of adverse events in gastrointestinal endoscopy. And I think it's important to standardize the grading of adverse events in endoscopy because it supports quality assurance initiatives. I hope you will read our article. I hope you will implement it in your clinical practice. And of course, we will be approaching all gastrointestinal endoscopy societies around the world to also implement this, because I think it will bring us further. Thanks very much for your kind attention.